Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Arginex.
This program is presented by Medscape Education Global.
Hello, I'm Heinz Windel, a professor of neurology at the University of Münster, Northwest Germany. I welcome you to this program titled Treatment Goals and Targeted Therapies in Myasthenia Gravis. Joining me today is Jennifer Spillane, consultant neurologist at the Guy's and St Thomas NHS Foundation, United Kingdom, London, and John Wissing, professor of neurology at the University of Copenhagen in Denmark. Welcome to the two of you.
Thank you.
Thanks for having us.
So I'm starting with a brief intro on myasthenia gravis, the key topic of today. So it's a rare autoimmune neuromuscular disease that causes debilitating, potentially life-threatening muscle weakness. It has impairment of psychological and social well-being. It makes fatigable muscle weakness. It has severe muscle symptoms. It's associated with lower physical scores, things like HR, QOL, quality of life scores. It impacts negatively on depression, and the quality of life scores are markedly lower in MG patients versus the general population. On the other hand, myasthenia is a very dynamic field, particularly with regard to how we understand the disease, but more how we now can treat the disease. The advent of novel therapeutic agents, novel classes of molecules has really changed the landscape dramatically. And we come from using acetylcholinesterase inhibitors, classical immunosuppressants, thymectomy, and we considered this fairly okay, but definitely we still recognize that 20% or something of patients are still not doing perfectly. Some would call them refractory to treatment, others would call them they are not optimally treated, or they are intolerant to certain treatments, including corticosteroids, for example. There is a lot need to change guidelines. They anyway have to be updated, but if there is not that much happening in a field, then the updates are not that mandatory. But that is different here in the condition of myasthenia gravis, and one update that I was part of is the recent German guidelines. We're still waiting for other countries or societies to update the guidelines, but this is one element we're talking today. So Jennifer, you haven't been part of these guidelines, but what are the key updates in terms of disease assessment in those guidelines?
Absolutely. So we read the German guidelines with anticipation and excitement, and I think they speak to what a lot of us are thinking about the assessment of myasthenia. So we really need to look at how we classify disease severity and how we categorize the patients. And we like to divide them, and we should divide them into highly active patients and patients who are less highly active. And the things that I think about when I'm thinking about a highly active patient are the severity of their clinical symptoms. Yeah. And you might use the very old scale that we've all known for years, like the MGFA classification. For that, are they ocular only, mild, moderate, or severe? You also need to look at how frequently they're having relapses. So, you know, the MGFA speaks to how they are at that one particular point when you're seeing them, but how many relapses are they having, and how is their disease severity? The other things we need to look at is their quality of life, how it's impacting on their life, and I suppose redefining what good looks like. So they're the kind of things we think about, and that's how we make treatment decisions and how we should make treatment decisions.
Yeah. Absolutely, fair point. What always has guided thinking not only diagnostically but maybe also therapeutically is the antibody status, John. How critically is this informing our instructing about the treatment concept, the management?
Well, we know that antibody status or measuring titers is it's not a very strong biomarker to assess whether you are actually successful unless they disappear completely. So that in a way is a little bit disappointing. I think there's an interesting development in looking at patients that were seronegative. The number of patients, seronegative patients, are dropping constantly. Many of them are acetylcholine receptor positive, just with very low titers. It's also interesting, I think, to look at in the ocular population. It has been said that they are much less positive, but at least in a study we did recently, they were not. But they have much lower titers.
Yeah.
And it could be that, for instance, ocular patients are just a particular subtype of acetylcholine receptor positive patients. And then, of course, it is really interesting to look at the different antibodies besides acetylcholine receptor antibodies. We have MuSK, and the treatments can, of course, be different for such patients. And LRP4 patients, which are very rare across the world, and we know very little about them because they're excluded from all trials. So we don't really have any evidence as how to treat them.
Yeah, thanks. So since this is an example of a very recent updated guideline, Jennifer, so what is, for the learners of our activity, a good summary on how we define disease activity and how do we deal with the terminology of refractory disease?
I think that's a really good question. And when I would have thought about refractory before, I'd have thought about patients who've tried everything and they've had disease for years and years and years, and you're at the end of the line and you call that kind of patient refractory. And, you know, we who've treated myasthenic patients, there are some patients like that, but it's a treatable neuromuscular autoimmune disease, and that's what we need to bear in mind. So I don't tend to use the term refractory in my clinical practice. I look at patients, I might say their disease is difficult to treat. I might say they've got high disease activity. I might say they've got a burden of disease, or they've got residual symptoms despite optimal therapy with what I've tried so far. So that's what I would call those patients. I would put them all into one box, and that's the box that I need to think hard about and say, what do we need to do better? And within that box, just going back to what John was saying, I might think about their antibody status, because I'll use their disease severity, the number of relapses, how refractory in old language that they are, together with their antibody status to decide what we should do about it. And I think the German guidelines that you were part of speak nicely to that point and summarize it really succinctly and beautifully.
Yeah, very good. So what we tried indeed was to give some sort of a operationalization of disease control, making a clear aim. So full disease control. Myasthenia is a treatable disease condition, clearly driven by the immune system. Full disease control as opposed to no disease control. And we made actually 4 categories from full disease control, bit comparable to what has been tried in the MS field with no evidence of disease activity, as opposed to full disease activity, no disease control. John, I mean, this is a new approach. On the other hand, there have been traditional approaches. You have been involved in a lot of those. Also descriptions of how do you measure the achievement of the therapeutic goals?
Yes. I think we are moving, and luckily so, into a more patient-centered assessment. In the old days, 10 years ago and before that, it was really physician assessed how the patient was doing. We were thinking very physically about everything when we assess patients. And I think with the advent of using the MG-ADL, which is a patient-reported outcome, as a primary endpoint in many of the recent trials, and it looks as if it will continue, I think this is, you know, a good step on that path, but I think we probably have to do much more. For instance, putting the PASS question to patients when they come to the clinic which is, this simple question of considering your symptoms now. If they were to stay the same for the next 3 months, would you be happy as it is? And they can say yes or no. It's a good key to sort of open a toolbox to go further in depth to see whether a patient is really doing well or not, because a lot of times it's not really the physical aspect of the myasthenia. It can be depression, it can be anxiety, it can be, a young patient that has just gotten the disease and the person is in a crisis, like with other chronic diseases, once you get the diagnosis. And I think we need to be much better at assessing this and also treating it.
That's a good bridge to what I would like to go next, is to have a look at key updates from the example of the German guidelines. So first of all, and that is no news, but it's just let's say, repetition of what traditional neuroimmunological concepts are aiming to do. Either you're so-called escalating, so you're escalating starting with a rather moderate activity of the treatment, and you're jumping what the disease dictates. That's the so-called escalation approach. You should also be allowed to do a hit hard and early. You could also say hit smart and early in a way. Approach means treat on target and consequently control the disease from the very beginning. This is what this, let's say, landscape of therapeutic options then combines in this guidelines, where we separate between mild, moderate, as opposed to active, highly active. We separate by the definition of the disease, ocular versus generalized, and we are separating by antibody status, and then you have a variety of options. And what you see is that for mild and moderate disease activity is a pretty standard and old school approach. Long-term immunotherapy of first choice is azathioprine plus corticosteroids. You can, in terms of intolerability, use other immunosuppressants of second choice. What are you doing to those that are defined as active, highly active, or severe, including refractory? And here we have two new groups. One is the group of complement inhibitors, the group of FcRn modulators. Complement inhibitors, we have 3, eculizumab, ravulizumab, zilucoplan. FcRn modulators, we have 2 currently, more to come, efgartigimod, rozanolixizumab. And we have also still rituximab, and then we have second choice of therapies. Very different, I would say, is really MuSK antibody positive myasthenia, because here we don't have any role of complement inhibitors. We have a very established role of rituximab, but we have a maybe increasing role of FcRn modulators that are partly on label also for MuSK positive myasthenia. So Jennifer, I hand over to you. Can you introduce the group of complement inhibitors as new, let's say, therapeutic elements in the armamentarium for generalized myasthenia for us?
Yeah, absolutely. So complement therapy has been a really exciting development in the treatment of autoimmune generalized AChR positive myasthenia. I'll re-emphasize that. And there are a number of different types, and we know that complement is involved in the pathogenesis of AChR myasthenia. We've known that for years. We know that from animal models, we know that from human studies, and we know that the complement system is activated, leading to the membrane attack complex, and that leads to destruction of the postsynaptic membrane. So complement activation is one, certainly not the only, but an important pathogenic process that happens in AChR myasthenia. And we can look at the complement cascade, and we know that there's different mediators within the complement cascade. A key point is C5, and then C5 leads to activation of C5b, so on and so forth, leading and terminating in the membrane attack complex, which leads to destruction at the neuromuscular end plate. And there are 3, as you mentioned, complement inhibitors that we know about nowadays, and I'll go through them in turn. Eculizumab was the first kid on the block a few years ago. It is a C5 inhibitor. It's an IV treatment. It inhibits the cleavage from C5a into C5b, and that in turn leads relates to blocking of the membrane attack complex formation. It's been around for quite a few years, so I think the EMA approved it back in 2017 for generalized myasthenia. Access obviously is varying from country to country, but it has been used, and the REGAIN trial did show efficacy. It's an IV treatment and has to be given 2 weekly, so that adds to the burden of treatment, which is the other thing we need to think about when thinking about treatment decisions for a patient, how much it impacts on their life. So there was some changes, and ravulizumab was created. As you know, that's a humanized monoclonal IgG that also inhibits C5, but unlike eculizumab, it's got extended dosing schedules. So rather than needing to give a 2 weekly IV, it can be given every 8 weeks IV, which the patients obviously much prefer because they don't have to come to hospital quite so often. And that's been approved by the EMA as well in 2022, I think, and its efficacy was shown in the phase 3 CHAMPION trial. Once again, it was approved by the EMA. It may not be available everywhere, so local guidelines do differ. But it certainly was an advance from eculizumab in terms of the pharmacokinetics. And we have a third one, so zilucoplan. So in contrast to the first two, this is a small peptide. It can be given subcutaneously every day by the patient themselves, so they don't have to come into hospital. It's also been approved by the EMA. Again, access varies, but the trial for zilucoplan also met its primary endpoint in terms of mean change in ADL score. And as we talked about, that is an important outcome measure that we're seeing increasingly used amongst most trials in clinical practice as well.
Thanks, that was very good and very, very educative. What about, John, the complement inhibitors in non-acetylcholine receptor positive myasthenia?
Well, Jennifer already touched upon anti-MuSK, and of course it's an IgE4 there, which doesn't really activate the complement system, so that's a no-go. The question is then, with the seronegative patients, we absolutely have no idea. Nobody's ever done this study. LRP4, very rare patients, but theoretically it should work because the IgG class is a complement activating class. So it should be tested, but I'm confident that it will probably work in this rare group.
Let's continue to the second big group of compounds, the FcRn modulators. John, can you introduce us to this group?
Yes. So, I mean, this is a really interesting concept, I think. I think in medical school, everybody has learned about the complement system. They don't know a lot about it, but they've heard about it and can speak a little bit to it. With the FcRn receptor, nobody knows about it. And, I even ask some of my medical students now, and also abroad, they don't teach this. And it's phenomenally important receptor that transports our proteins across cells. And if you don't have this receptor, that the proteins are destined to lysosomal degradation, you lose the protein. So it's very logical then, if you block it, you can get rid of proteins. So antibodies have been produced then to block the FcRn receptor, specifically not to take all proteins, but mostly IgG. So you can say, in a way, it's an internal plasmapheresis. And there has been right now two drugs on the market, efgartigimod and rosanolizumab. And we can briefly look at some of the results from this. So they differ a little bit in the way they are built up. I wouldn't say so much how they work, and the side effects are actually quite similar. The first study that was tested and approved was efgartigimod in the ADAPT trial, and it was a brief trial where patients were dosed weekly for 4 weeks, and it was about 170 patients included in the trial, and as graphically shown here on this graph, we can see that the primary endpoint was the MG-ADL. and there was a very clear separation. Patients on efgartigimod fared much better. Interestingly, it was also a very quick response. So even after just a week or two, very clear separation, even though the placebo response was actually quite large as well. This is something we actually have seen in many myasthenia trials, that the placebo response is quite big. But still, it's a very nice separation here in this case. So this was an IV formulation, and now you can also get efgartigimod subcutaneous. It's been approved for this, but obviously, as for the CE5 inhibitors, not reimbursed in all countries. The other drug in question is rosanolizumab. It was a trial of about the same size, slightly bigger. And in this trial, and it's shown on this graphic here, we can see that the patients were treated with 2 doses, a 7 and a 10 milligram dose. And actually the response was fairly similar for the 2 doses. And now it's the 7 milligram dose that has been approved. Also because the higher dose had a slightly higher side effect profile. So these patients it was a quite similar approach, weekly dosing, but in this case for 6 weeks, and showed again a very nice separation, again using the MG-ADL as the primary endpoint.
What do we know, John, about the adverse event profile of those FcRn modulators?
So headache is usually the most common problem, and usually it's worse in the first dosing, and then it seems to disappear. And the same is actually true for gastrointestinal symptoms. They're not as prominent, abdominal pain, diarrhea, but it also tends to get less.
But in contrast to the complement inhibitors, there is no need for a vaccination.
No. And the infection rate was fairly low in the trials.
Is there still a role for rituximab, CD20?
Yes, and it's kind of like an odd drug that has come in. It's completely off-label. And as with many of our other really old drugs, and this is not the oldest, it came a little bit later than the really old ones, it has just come in to the myasthenia field, and there has been a number of not very well-controlled trials that were sort of negative for general myasthenia patients, including the acetylcholine receptor positive patients. BEAT-MG trial in the US was negative, actually, and it was also a huge multi-center over many years. It was not very well designed. In MuSK patients, repeatedly in many small trials, it's small trials but very convincing numbers, it has shown great effect. And then the Rhino trial in Sweden was sort of a very important study because it showed that patients who had a recent onset of myasthenia had a really good response on rituximab. So I still think there's a role for rituximab, but we need to find out exactly where to place it, probably in more newly diagnosed patients.
Maybe to round up the discussion to the two of you, so what does the advent of this novel treatments mean for your management? So how has it changed? Maybe Jennifer, you start first.
Yeah, I think it really has changed things. It's changed how we assess our patients. It's changed what we can aim for. You know, we can aim for better than we aimed previously. We can offer our patients choice. So previously there were, few non-specific agents that we did use, and I'm not saying they didn't work. They do work, and they often will still form the backbone of treatment for patients with myasthenia. But now for the patients where that doesn't work out, either because of side effects or because of lack of efficacy or because of frequent crises, we've got other options. And as we were talking about with the newer treatments, so the FcRn and the complement, some are IV, some are subcut, there's different dosing schedules that can be used. So it's really just opened up the choice for our patients and allows us to individualize care rather than a one-size-fits-all. Yeah. So I think it's a really exciting time.
John?
Yeah, I think with the advent of all these new drugs, it's one thing is that you can actually treat patients better, and especially those that we could not treat so well before. But it has also spurred a lot of interest in how we are looking at the disease and the patients and how we assess them. So we are getting better tools to find out, how we should follow them. Also, there are apps are coming up to follow patients online. I think that will be a great help in following patients and see how they treat. This would also have been the case years ago with the old drugs, but now it's like the whole development has moved in this direction and creates another opportunity.
I mean, one really standout of this novel therapies is this fast onset of efficacy. Yes. On the other hand, the reversibility, so you really know what you're doing quite quickly. This is very much different to, let's say, the other disease-modifying treatments. How about the midterm, long-term safety concerns? Is there anything that would bother you, or what would be your comments here? Maybe Jennifer and John, your thoughts about that?
Well, I think just to speak to your first point about the rapid onset, I think that's fantastic because whether it's working or not pretty much straight away. And I used to feel fairly embarrassed when I'd say to my patients who I was starting on a non-steroidal immunosuppressant agent, it's not going to work for 6 to 12 months potentially. And the patient is looking at me not very happy. So I think that's great. And, being honest, we're still learning about these treatments. So we're building up our real world experience of the FcRns and the complement inhibitors. And there's increasing number of publications all the time showing how these agents play out in the real world. In terms of the long-term safety, I think we need to watch the space and continue to learn, and that speaks to the importance of registries. With the FcRns, we've treated patients with plasma exchange for quite a long time, so I suppose we could extrapolate some bits of information from that about lowering IgG levels, and perhaps not if they're in the midst of an infection when humoral immunity might be really important. Complement inhibitors, we already talked about the importance of the meningococcal vaccine, and that is something that needs to be monitored and watched for, but we really need to get real-world clinical experience to get long-term data on safety.
Yes.
What would be your, let's say, biggest concern about long-term safety issues?
I don't really have any very big concerns, and I think, because I completely agree with what you said, Jennifer, and I also think it's not that new. If you look at the patient years that patients have been treated with these drugs, then we are getting there to have a quite good experience. And I think it is fair to say that generally the side effect profile is actually more favorable than steroids, which 50% of patients are on.
Yeah, which is also some upcoming novel, I wouldn't say dogma, to really try to get rid or to at least reduce to the best possibility the steroid use. So it's exciting times, and thanks for your insights and contributions. So let me conclude. I think myasthenia gravis shows to be the new MS in a way. Very dynamic development of understanding, managing, and treating the disease, novel concepts. The beauty of the two additional molecular classes that really have changed so much, the complement inhibitors, but also the FcRn modulators, is the selectivity on one side, the velocity of the onset, the reversibility, the offset. And I agree that very categorical adverse events, albeit that shouldn't be downtoned at all, we have to monitor those patients. They are severely affected patients. They have multiple possible comorbidities. They have combination therapies. But on the other hand, if you would see those principles in isolation, there is not that much of categorical concerns on the classical burden of long-term immune suppression. As said, anti-MuSK is a standout. There is no role of complement inhibition, but there is a role of FcRn modulation because of the scientific and immunological rationale. And we get more ambitious, and we can allow to be more ambitious in terms of what we aim as a disease control. You both said that, and I completely agree. It will move from physician-centered to patient-centered, so full remission, best possible disease control should become our standard. Jennifer, John, thank you very much for being with me and for this great discussion. Thank you for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation. And thanks for attending and listening.
This program was presented by Medscape Education Global.